The gravity of the time is such that every new avenue of peace, no matter how dimly discernible, should be explored. Never before in history has so much hope for so many people been gathered together in a single organization. You will provide a great share of the wisdom, of the courage, and the faith which can bring to this world lasting peace for all nations and happiness and well-being for all men.
So we are here today with Dr. Mohammad Khan, who is a physician scientist and an associate professor of radiation oncology at the Winship Cancer Institute of Emory University. Dr. Khan, thank you so much for taking the time.
No, thank you for the opportunity.
Yeah, we're super excited to learn about your work, especially as it relates to COVID. But first, maybe could you just give us an introduction as to your past, your history, stuff you've worked on before?
Sure. So I, am a nuclear engineer by background. I did my PhD in nuclear engineering at the University of Tennessee, Knoxville, where my focus was on health physics and medical physics. And more specifically, my research involved image fusion and image registration to help improve treatments for glioblastoma patients undergoing trials. And I got interested in clinical research and taking care of patients at the bedside. Therefore, I went on to receive my MD from the University of Tennessee in Memphis. And then radiation oncology provided me the best field to have patient access, patient care, and bring innovation to the patient bedside. And then after I finished my radiation oncology residency training at Cleveland Clinic, I joined Emory University in 2011, and I've been here since then. And I'm currently an associate professor who focuses on translational research and bringing innovation and new ideas to patient bedside to help improve their outcomes and help them live longer and have better quality of life using radiation principles.
Amazing. So you are, so first you got a PhD in nuclear engineering, and then you got, you became a doctor as well. You got an MD after that?
Yes.
And just so I fully understand, in addition to, do you have an active, an active practice where you treat real patients in addition to also being a professor also?
That is correct. So I treat patients with radiation every day, at least 2.5 days a week. I do that, and I actually have a basic sciences lab. We actually radiate mice and do experiments with radiation, and then we do clinical trials off of that, and take those clinical trials to patient bedside and help further advance their treatments and help bring new ideas and new treatments for them in the future.
So you're a scientist, a professor, and a doctor.
Yes. So I wear a lot of hats. I'm considered a clinical scientist, or a clinical scientist who does clinical care, takes care of patients using standard of care treatments, standard of care approval processes. But then also I'm a scientist where I bring new things, new ideas, new indications that we learn in mice and experiments in my lab. And then we do clinical trials to help bring them to reality and help advance and bring the new treatment to their bedside, to the patient in the future.
Now, before we get into the use of radiation therapy for COVID, can you maybe just give us a little brief history of how radiation has been used for medical benefits overall and in other spaces as well?
Sure. So, radiation was discovered as early as 1895 by William Rankin.
You said 1895.
1895. 1895. So I give these lectures to my residents. 1895, they discovered X-rays, and those X-rays, within a year after that, 1896, they started radiating skin for skin lesions, and they did really well. And shortly after that, 1906, the American Dermatology Association, they thought it was the biggest breakthrough of its time to help treat skin cancer patients in 1906. 1906 was a big meeting in Washington that talked about this. And it was, the minute it was discovered, I mean, radiation has been used for over 100 years to treat skin cancers, even benign things. Back in the old days, they were using it for pneumonia before antibiotic era. They were using it for skin to try to get rid of alopecia for patients. Yeah, for lots of inflammatory diseases on the skin was used. For acne, for example, it was used. Matter of fact, there were orthovoltage tubes to help put patients' feet and fit them for shoes, things like that. And I think that the field was still learning what are the appropriate uses, and we also learned what were the inappropriate uses of radiation back then. So that was done, probably 1920s until probably 1940s and 50s. And probably after the 1950s, we really figured out that radiation was a big therapy, standard of care for lots of cancer treatments.
So, oftentimes people think of radiation as a scary thing that causes cancer. But the more that I learn about it, the more I realize radiation has probably cured far more cancers than it has ever caused. Is that right? And what orders of magnitude are we talking about here?
Huge orders of magnitude. I mean, when we think about a 70-year-old or a 60-year-old patient who's got cancer, in some of their cancers, cure rates are well over 95%, 98%. So, for example, skin cancer patients, that's a bulk. That's 3.5 million patients out there. The cure rates for them is with skin cancer for early stage, it's 95%, 98% with radiation. The likelihood of them developing a secondary cancer from that is virtually non-existent. To almost, I mean, it's much less than 1%.
So we're talking about we apply radiation to millions of people we save millions of lives from cancer every year using radiation. And what are you mentioned inappropriate uses. What are some examples of when radiation has actually caused cancer?
Yes. So I think, in the when radiation was discovered in the early 1900s, 1900, 1910, 1920s, they were starting to use it for what I would think was probably inappropriate uses. I think it was great to be able to image a patient's foot and to be able to look at the bones and look at the anatomy, but the indication were not to treat a disease process. The indication was just a cosmetic to try to generate nice images, but then also for foot fitting, if the shoes fit and the sizes fit, all of those. Back then, they didn't realize the late consequences 20, 30 years later, which can lead to small risks of secondary cancers. And then when they started treating children and younger patients, that was a bigger problem for the radiation oncology field. And I think we learned from those mistakes that we should only use it for things that we can help patients for disease, for example, cancer. We know if the cancer is not treated, patients are not going to do well. Some of them may actually die. They may end up with problems, pain, bleeding, ulceration, all those things. So radiation makes perfect sense to help alleviate all these. And the small risk of 10, 20 years later for small risk for cancer, it's not something that we would even think about. I don't think that the benefits outweigh the risk clearly in those settings.
And going back to that case where I've even seen, articles about this online, how they used to, you go to the shoe store and you put your foot under the X-ray machine and you map out your foot that way. How many people actually got foot cancer from that, or some sort of cancer from that?
It was, if I remember, it was still very few. It was a very small percentage of patients. But I think the excitement was just, hey, it was a new technology back then. Everyone wanted to see what their bones look like, what their looks like, and I think that actually led to a lot of Superman comic books of X-ray vision and being able to see. It was an excitement to be able to see inside your human body using X-rays, and that never existed before.
And just so we do understand what the risk is, if you do use an inappropriate amount of radiation for these cosmetic reasons, where does it actually hurt you? Like, what does it cause? Does it cause a bone cancer, a blood cancer, a skin cancer? If you're just shining it on your body just for any old reason, what is the negative way that it interacts with your body? Just so we fully understand the range of risks.
Yeah. So I think, we think about several elements of radiation. We think about the energy of the radiation. We think about the radiation dose that we're giving, the volume that we're treating, and then the age of the patient. I think will determine their risk for cancers and what type of cancer that they will develop. If you're directing it to a skin, very superficial, small area, risk is probably non-existent or very minimal. But if you're treating like a total body patient, like an entire body, like for example, I treat patients with leukemia, and sometimes I have to treat patients that are very young because they have leukemia. That's a very deadly cancer. They will die from that if you don't treat them. And I treat them. And sure, we understand there is a risk for secondary cancers many years down the line. But for those patients that have a very short life expectancy without a treatment, they're happy to trade off that risk late, many years down the line. For them, surviving is more important than worrying about a 20, 30, 40-year later risk of having a second cancer.
Yeah, so let's talk about that. Leukemia. Is leukemia a blood cancer? Did I get that right?
Yes, leukemia is a blood cancer. That is correct.
And so what is the mechanism? Let's say you give someone a full body dose of radiation treatment. What is the mechanism by which the X-ray or the radiation will negatively impact the leukemia, the blood cancer floating around throughout your circulatory system, more than it hurts the normal cells that you have throughout your body?
Yes. So we know that cells that are carcinogenic, that are proliferating, that are growing faster, and which is what makes them cancer, as opposed to other cells that are not proliferating at the same, rate. And then those cancer cells don't have very well defined repair mechanisms. So when you damage those cancer cells with radiation, that damage is not repaired very well. And these cells, because they're proliferating, are much more sensitive to radiation-induced damage, and they die off. Your normal cells that have very good repair capability, they repair, they rebuild, regenerate, and so they go on and they do well. And for leukemia cells, we do radiation, and there's two kinds of radiation we do. One is what's called myeloablative. We're giving higher doses to directly destroy the leukemia cells, to try to wipe them out in areas that these leukemia cells hide in sensory side, like in the brain and the testes and things like this, and a lot of the bone marrow spaces that even chemotherapy can't get to those areas. Without radiation, these patients will not do well. So therefore, we offer radiation to get rid of all that leukemia. And then we also cause suppression of their immune system so that they can accept someone else's stem cells to become part of their body. And then someone else's stem cells start to grow and reproduce the blood counts, the white blood cells, the platelets, all those things that they need to survive. So that's a myeloablative regimen. Now, there's another regimen of radiation that we use, which is very low dose radiation. It's a lower dose. It's around 2 gray, a single fraction. That's called reduced intensity radiation, where all we're really trying to do is to modulate the patient's immune system, not necessarily causing a cytotoxic effect, but mostly an immunomodulatory, where we suppress their immune system so they can express and accept someone else's stem cells, and then those stem cells reconstitute in the patient and help lead to a leukemia versus graft host effect, where the graft gets in and destroys the leukemia, and the body doesn't reject it because you use low doses of radiation to suppress their immune system. And we do that for elderly patients.
Yeah, how does that work? How does, let's say, a 2 gray is what we're calling a low dose?
Yes.
How does a 2 gray, and over what period of time is that? Is that over a second, over a minute? What period of time is that?
Yeah, so it's a reduced dose rate as well. So it takes about 15, 20 minutes to actually deliver the 2 gray, and it's an extended distance. So it's a very, very reduced dose rate that we give that radiation as well.
And how does that suppress the immune system? What even is the immune system that can shoot light waves at it, and all of a sudden it calms it down?
Yeah. So the immune system is things like your immune cells. So this is what we're born with. So these are the lymphocytes. For example, the CD8 T cells. These are cells that are involved in sort of eradicating cancer, like using the immune system to wipe that. A lot of the drug companies are developing drugs that can alter the CD8 T cells. There's also B cells that help produce antibodies. So these are sort of the cells. There's many cells, so natural killer cells, antigen presenting cells. These are all multiple cells of the whole immune system, and they all play different roles, and they all interact together to help, destroy infection or help remove cancer, things like that. And radiation can help reduce or alter the function of many of these cells.
And maybe I'll just double click on that a little bit further. How does it actually alter the function of a cell? Does it make it uptake a chemical more selectively? Does it destroy a certain percentage of those cells so then the other cells do something else in response? What is it actually doing when you send these X-rays into a person? Like how does it touch the cell?
Sure. So I think X-rays, are very different. They're not just one energy X-rays. And so depending on how you alter those X-rays, where you go to very high dose of radiation, where we're trying to ablate tumors, that causes different physiological effects in the tumor. So for example, high dose of radiation, which we call hyperfractionation, can alter the cancer cells, where those cancer cells, it causes damage in the DNA, and that damage can lead to antigens to be secreted on the surfaces and around the environment. So that's those tumor cells that are hiding from the immune system look different. They look altered, and your immune system can recognize them. And there's many, many things it's like antenna receptors, where you've just taken something that's hiding, you put an antenna receptor on it, and your immune system can see it. And then because you've caused antigens to be shed, you've changed the alteration of the surface of them by causing MHC class 1 expression. You've changed the whole environment around that. So basically something that's hiding has now come out of that. I'll give you a great example that I give to my patients. For example, if you have something that's hiding in the bushes, and you want to be able to make it visible, and you want to make it come out of the bushes so you can see it, you target that bush and you add radiation to it, and that cancer doesn't like that bush, and he wants to come out and be seen by the immune system because he doesn't like what's happening in that environment. It comes out. And
like
that's
blasting a foghorn or something. It startles everyone and people move from their hiding spots. And then the police can look around and say, there's the bad guy.
That's exactly right. And that's where the hyperfractionation, ultrafractionation, we're trying to destroy that tumor. It makes it it damages that tumor, and he wants to come out of his hiding place now.
Okay, so that's high doses. What's the mechanism for the low doses?
So the very, very low doses are where it changes the way that tumor is active, or not the tumor, but I would say the immune system is sort of functioning. So there's a nice paper that I can talk about that came out from Gustave Roussy from France, Eric Dosch's lab, where it looked at the one of the immune cells that are involved in inflammation. For example, the what they call the macrophages, and looked at the production of those. So they looked at these what they call the nerve and airway. So you have nerves and airways, and there's macrophages that sit around those airways. And they looked at what happens with low dose of radiation, like 1 gray. And so these are cells that are supposed to be inflammatory. These are the ones that cause inflammation. And the thought was, what will low doses do to those cells? And can they change them from being inflammatory to anti-inflammatory? And the way to measure that is to look at things that these cells release to cause inflammation. So for example, when they become inflammatory, they're going to release IL-6 or interferon gamma, things like this. And the low doses, what they showed in a mouse model, where low doses actually reduce interferon gamma production and reduce IL-6 production. And then there's another cytokine that's released, which is called IL-10, and the IL-10 was actually increased. And that's another mechanism by which they were able to conclude that low dose radiation converted those cells from from inflammatory to an anti-inflammatory. And the nice thing, they did some images where they took a mouse and they took X-rays where they injected these sort of what they call a poly-IC or LPS into the lungs to cause a RDS type mouse picture in the lungs of these mice. And when they give low doses, they show that the not only mechanisms wise, where those macrophages converted from an inflammatory to anti-inflammatory, but the nice images actually show where the pneumonia in the lungs actually reduced and disappeared and got better with low dose of radiation. So a good analogy could be like, for example, you have we all have children, right? And your children's not behaving, right? And they're acting up. You give a little consequence. Say, hey, look, if you don't behave, you're going to get a punishment. And so these immune cells are same thing. They're inflammatory. And you're saying, hey, you're going to get a consequence if you don't turn around and you don't behave and become anti-inflammatory. You better behave. And low dose radiation can alter them to saying, hey, you need to behave. You need to cut down the inflammation. Things like this. And there's mechanism biology that describes that.
So now, okay, so this is a perfect segue into what's going on with COVID, because one of the problems, and correct me if I'm wrong, but one of the problems that I understand is causing a lot of deaths for people who get COVID is not actually the COVID itself, but it's the body's overreaction to the COVID that leads to inflammation, that leads to pneumonia, and then that's what kills you. Is that right?
That is correct.
And so what we're targeting with the radiation is not necessarily the COVID itself, but what we're targeting is the body's immune response to the COVID that oftentimes leads to death.
That is correct.
And so now maybe if we could rewind to history back a little bit, because there is an analogy, or there is there was comparable work done in this space, specifically with pneumonia. And we know pneumonia is that response to COVID that leads to death. We've had pneumonia for quite a while. I know there's bacterial pneumonia and viral pneumonia, and antibiotics can treat bacterial pneumonia, but viral pneumonia has always been a little harder to treat. But they tried doing this way back when, right? With radiation?
Yes, that is correct. So if you recall, we talked about radiation being discovered in 1896 and 1895, and right after 1896, and 1901, 1902, some of the early publications came out about how radiation can help skin cancers and things. And shortly right after, in 1905, in University of Pennsylvania, there was pneumonia and people were dying at a relatively rate. There was not a lot of options for the pneumonia patients, and they then directed the radiation to the lungs. And they found the pneumonia within I think 6 hours or within 8 hours, these doctors would see these patients start to improve. Their breathing would get better, their temperatures would drop, their white blood cells would start to get better, and clinically the patient would be improving. And within 2 days or within 3 days after that, the X-rays also showed signs of improvement. And that worked from 1905 to 1910, 1920s, just escalated. There were more and more papers and more publications that came out in that era. And I think there's reports of like 700 or 800 patients in that era that were treated successfully with radiation, low dose of radiation, to sort of help them get better from pneumonias.
And it's as I understand, sometimes it's hard to tell, in the medical space, when you do something, if that thing actually created the positive effect, or if the person was just going to get better anyway. And that's why we have these controlled studies. But is the burden of proof a little bit lower if the result is so drastic so quickly, like what you were talking about with 8 hours? Is there a different metric that we use to measure that type of effect?
Yeah, that is correct. So, so number one, I think that's one of the thing about the pneumonia literature back then. They didn't do a randomized trial, and partly because I think there's some actually discussion that said it was probably immoral and unethical to even do a randomized trial with something that has such a big effect with something you have no other options for. It's kind of like, who's going to do a randomized trial to prove that parachutes work, right? You can jump out of an airplane and have another cohort of patients that are not going to get a parachute. But, as scientifically, we can say, hey, there's no randomized trial to show parachutes work, right? Yeah. But is it more ethical to do that? So, but regardless, I agree. I think the scrutiny and the proof of burden was not made available in the era of pre-antibiotic of the role of radiation for pneumonia, but it was used. And when antibiotics came out, I don't think people have done those randomized trials of antibiotics versus radiation back in the era for pneumonia. So that whole data just sort of got put on the history shelves.
But that surprises me because, X-ray style machines or radiation style machines are widely available, especially the diagnostic types. And we have billions of people on this planet, and not everyone has access to fancy hospitals. But, it seems to me, a 15-minute blast of radiation to treat pneumonia, and there's probably, millions of cases of pneumonia around the world. It seems to me like over the last, 100 years, this would have been a fairly common practice to treat viral pneumonia specifically.
Yes, that is correct. So I think a couple of things. I think number one, probably because the antibiotics were easier to administer at the patient bedside. Patients there in the hospital, you give them, as opposed to transporting them down and radiating them, things like this. Just number one, it was easier. And I would suspect the antibiotics were probably cheaper to give as opposed to X-rays back in the days. And then I think as a field, because remember, you got people that were using radiation for what it was meant to be and balancing the risk versus benefits on behalf of the patients.
Yeah.
I think we're championing and advancing the field in the right direction. But you also had other people with other means that were doing it for fun. They were doing X-rays for the foot, or they were doing it because they want to have more customers to come into their shops so they can get the right media attention or the right I would say from a financial perspective, where they were using those X-ray ultra voltages to sort of show some nice pictures so that most customers would come in and buy their shoes. And that probably wasn't the right thing. And I think, and in those cases, it hurt the field as radiation oncology because then those patients did develop skin burns or they did develop some toxicity or late cancers and things. And I think, and then also, I think that part of the negative attention overshadowed the positive attention, the positive things of radiation. And therefore, I think at that era when radiation could have been used for pneumonia fell apart and was never really championed and pushed forward because the worries about the late risk of secondary cancers. And then also, if antibiotics were effective and cost, didn't cost much, it made more sense to continue with antibiotics at that era.
Yep. Just one quick point to clarify that though. But the antibiotic don't work for viral pneumonia, right?
That is correct. We don't, and they've tried this for COVID-19. Azithromycin did not work. Antibiotics did not work for viral pneumonia. That is correct.
And then what have people been doing for viral pneumonia over the last 60 years?
I think they've tried a lot of different things. They've tried a lot of antiretrovirals, things like this and some of them have worked for different indications. Like for HIV, they use antiviral all the time. Like heart therapy works very well. So there's lots of antiretrovirals that do work for various indications.
But that's even a fairly new thing. I mean, let's say 40 years ago, when someone got viral pneumonia, did doctors tell them, hey, just tough it out and hopefully you'll get better or you're going to die, essentially?
Yeah, I think they just tried off the shelf things to try to help whatever they could.
Yeah. Okay, so now let's fast forward to COVID. It's March. Everyone, is freaking out. Things are being shut down. We already know at this point that it's a respiratory disease and then it goes after the lungs and that it causes pneumonia and that's a common cause of death. And that's when there were only, maybe, 10,000 deaths in the country or and maybe, double that worldwide or whatever it was.
Yes.
But people were freaking out and we've got a whole discipline of people like yourself who have these ideas and they're like, okay, like this might work. What happened back in March, April with respect to these ideas?
Sure. Oh my God. So I agree. So I think to me, in February, I'm sitting there in my clinic and all of a sudden, patients are afraid to come. As a doctor, I'm actually afraid to walk in and seeing my patient because I'm afraid of getting sick and carrying that virus home to my children and my wife. But as a doctor, we do what's right. We put our fears behind us and walk into the room, and our patients need to be treated. And it was a very grim moment. And I almost felt like I'm sitting what might have felt like in 9/11 when we saw this in 9/11, where we were just in shock and awe, all of us, of what is happening. And then you got heroes like the firefighters who say, look, we're going to go out and save the lives. We understand the building's collapsing on us and thousands of lives are going to be lost in that building. And they ran in while the fire was on and they ran in, they got their gears on, they got their, whatever they could do and saved as many people as they could. So similar to us, we have ideas. We can sit and brainstorm on those ideas forever while we lose lives in front of us. I could not see that. In my own field, people came out to criticize our ideas, let alone outside the radiation field, pulmonologists, everyone else is like, you're going to do what? But I could not see lives being lost and me sitting by and not being part of a solution and actually becoming part of the problem.
Yeah.
So some of those people actually became part of the problem by not wanting to do something and probably because they're feared. They don't want to treat. They don't want to be at the patient.
Well, this drives me crazy because the whole world was in emergency mode, when this, in last spring. And it seemed to me, just like as an average citizen, hey, let's try everything. I don't care how out there it is. Like, it doesn't have to work. People are dying anyway. So let's just throw every drug at the wall, every therapy at the wall. And yes, some of them might seem silly or seem stupid, but if people are dying anyway, especially as they get to a certain progression in the disease, like we already have precedents for allowing doctors to try random things on people who are about to die, right?
Yep, that's correct. So
So,
you're correct.
and yet there was still resistance.
Oh, a huge amount of resistance against radiation. Oh my God. People thought using radiation was the craziest idea ever. They thought people were nuts to even think about it, you know, and partly because people forgot history. People didn't realize that radiation was done for pneumonias. And then they find reasons to sort of discount radiation because they said, oh, that's with bacterial pneumonia. This is a viral. This is ARDS. This is inflammatory. This is very different entity. And matter of fact, they say you might actually make things worse and kill patients. So basically, they found a reason to not want to champion radiation, something that can help. And it really took a different kind of individuals, I would say radiation heroes, to champion this in a time when there was plenty of bars against those that believed that radiation would help COVID-19 patients.
So tell me, what did you and your community, your group of heroes, what did you have to do to like get things moving?
Sure. So first is, similarly, it was a scientific leap of faith. It's sort of like, okay, we understand the mouse models weren't there to really do that. The historical anecdotal evidence was there in the 1920s and 30s, but hasn't been used recently. And we knew there's going to be a huge bar and barrier to get people to be convinced. So basically, what I did was I built a team here at Emory. So I talked to my junior colleague, Dr. Clay Hess, and said, hey, let's think about this. Let's brainstorm on this because we can change the pandemic. We need a therapy. We can't stand by. Yeah. And if you remember, hydrochloroquine came negative data, and there was nothing else at that point because that was the only thing we were hoping would have worked, and it wasn't. And there was a moment of silence. And right. There was nothing else.
We have to remind people, like, we still don't really have a good, like, we got some stuff, but like there's no like real good therapy. Like the vaccine is different. Vaccine is about prevention. Therapy is about once you already have it, which millions of people do, or tens of millions of people have it, this is about helping them. And there is no real good option out there right now.
That is correct. There is no really good option out there. So if you look at the number of patients that get diagnosed, the data suggests 1 out of 5 are going to end up in the hospital. They're going to need oxygen and support.
Yeah.
If you look at in February and March, if those patients end up in the ICU, the mortality rate, the probability of dying in the ICU was 50 to 80%. And these hospitals were getting flooded of deaths, and our hospitals were shutting down. And we're basically, we were shutting the entire economy shut down. The entire world shut down.
Still shut down. And okay, so 50 to 80% of people who get on the ventilator, essentially, is that the number of people who die?
That was the numbers back in February and March. 50 to 80% were going to die if they end up getting intubated.
And what about now? What's the data now on that?
Now, so the only therapy that has had some success in the intubated patients is steroids. And that has reduced the mortality down to about 30% probability. So there's still a 30% chance that within 28 days, these patients are going to die. That's still a very high mortality rate. I don't know if any cancers that has a 30% death rate within 28 days.
And yeah, that's crazy. And the way that steroids work, is that in a similar function? It reduces the immune response?
That is correct. So it's anti-inflammatory. It reduces some of the cytokine storm and reduces some of the lymphocytes and their function also. The exact mechanism, they still don't know why steroids does this. No one knows the exact mechanism. They just threw steroids out there as a guess and said it might work and let's try it.
And and are there downsides to the steroid doses that they're using as well, or is this a free pass if they try?
Yeah, no, there are downsides to steroids. It can cause reflux. It can cause long-term use. It can cause bone loss. It can cause alteration in the endocrine function of the patients. It can worsen diabetes, and it can worsen pre-existing if they have like a superimposed bacterial infection while they have a viral. Because some of the lung patients actually have both. They'll have a viral-induced pneumonia, but they also develop a bacterial. Those bacterial infections can get out of control with steroids too. So there are certainly consequences of steroids.
Okay, so tell me, where are the studies now? So you and your team have been pushing to study the use of radiation, and can you actually walk me through how much radiation is it compared to what they did historically? What do you think is the right dose of radiation, and what are the mechanics of how you give people a dose of radiation?
Oh, perfect. So all good questions. So number one, when we started reviewing the data in February and March and realized there is an argument, a scientific argument that we can put together with limited data sets and both mouse data set, preclinical data set. It wasn't ideal, it wasn't great, it wasn't perfect, didn't quite fit, but still, it was a scientific leap of faith that it should work. So we put all that together, went to IRB, got a protocol. You can imagine trying to get IRB to approve was not easy. Trying to get our own departmental team leadership to buy into it wasn't easy.
When you say RP, are you saying like review board? Is that what you mean?
Yes, the internal review board that looks at the morals and ethics of a clinical trial. We're the first one in the world to be doing this, and there's no precedence for something like this.
And let me ask, when hydrochloroquine or some of these other drugs are anywhere of 1,000 drugs that they potentially use to try to work to develop a therapy for COVID, were all of these done through clinical trials, or were some of these used off-label or off-procedure just to see what might have worked? Gathering, go ahead.
Sorry, many of these were used off the shelf. Hydrochloroquine was used off the shelf, but the bar is not. It's easy for them to use off the shelf. Any drug off the shelf, you would have as much issues getting it approved as opposed to bringing radiation in. The scrutiny with radiation was a whole lot different element than any off-the-shelf drug that don't have indications. And it was easier to use drugs versus radiation.
Why? Why is that? Is that a function of the review board's procedures, or a function of how hard it is to access the equipment? Why is it so much easier to use drugs rather than radiation?
Because it's just inherent bias. It's just an inherent bias saying it has to be a drug, it has to be an antiviral, it has to be this. And that's why remdesivir was easy to get into trials. The hydrochloroquine was easy to get into trials. Many other things they used were ropinavir, ritonavir. That was also came back negative. That was also easy to get into trials. There was no issues with getting those approved, because just an inherent bias. It has to be a drug, and it cannot be radiation. That's just the nature of what people believe.
And so tell me, but you were able to have some success. There are some trials right now going on that are studying the use of radiation therapy on COVID?
That is correct. So the nice thing is, so we did the first trial in the world. We asked IRB to allow us 5 patients just for proof of principle. We're not asking for it to conquer the world. We're just taking small steps. And if we can show that radiation is safe in those 5 patients, IRB would then give us approval to do many more. All right. And we were and with the 5 patients, they were all elderly patients, majority of them. They were all sick. They're to the point where they were actually crashing, and many of them actually had worsening brain function as well too, because the clotting was probably impacting their high oxygen levels in the brain, and they were getting demented, and their Glasgow Coma scales were dropping. And the nice thing is, the first day when I walked into the patient, we brought them down on a Friday evening after hours, radiated the patient. The next morning, we walk in, the patient actually has a Zoom conference with her daughter. And that was amazing to see.
This is someone who's about to die, and a day later, they're chatting on video chat.
That's exactly right. And that patient was and to me, that told me there's a signal. The first patient that got on the trial, second patient, the same night Friday, we treated 2 patients. I can't give the exact date, but well over 90-year-old lady. Similarly, the next day we had a whole conversation. She talked about her favorite sports team, Atlanta Braves, and how she loves the Atlanta Braves. And we had a nice long conversation with her. And it was a completely different turnaround. And within 24 hours, the patients were coming off oxygen.
Yeah.
And these were patients that were not able to come off oxygen.
Yep. So any doctor looking at that situation would have said, I predict this patient is going to die. And yet here's almost a miracle. They are back to normal within 24 hours.
Yes, that is correct. Those are the texts we got from our referring doctors here in Emory. Those same doctors that were skeptical about radiation. Their text is, oh my God, look what just happened. So I didn't need any more science after that to know it's going to potentially work, and we just need to keep moving forward.
All right. So then what happens? So you get 5 patients, and then how do you get more now?
Yeah, so with 5 patients, we have an 80% response rate. At our mean time to getting patients off oxygen was 1.5 days. So 1.5 days, these patients are coming off oxygen.
That's
If
amazing.
they didn't get radiation, they're on oxygen for a lot longer than that.
That's amazing. And then so okay, but how do we now increase the size of the
Yeah.
study?
So then I went back to IRB and gotten more approval. So we gave another 5 more patients to reproduce the signal because there's still skepticism. Maybe we got lucky with the first 5. Then we did 5 more patients and saw similar response rates. Our mean time to get the patient off oxygen was 3 days. And what was happening is all of these 10 patients, when we looked at that data, 3 days they're getting off oxygen. By day 12, they're getting out of the hospital. They're going home to their loved ones, their family ones.
Yeah.
And that was amazing. And then also what we found, only 1 out of the 10 patients end up in the ICU. So 90% of the patients did not end up in the ICU. And then what we did was, because we know criticism is going to be like, oh, you don't have any comparison, you don't have any comparative cohort. So we took 10 other patients that were age matched, comorbidity matched, and disease severity matched.
Yep.
To saying, hey, if these patients did not get radiation, what would have happened? And it turns out those patients that would not have gotten radiation stayed longer in the hospital till almost 12 days before they came off oxygen. And they were so 3 days versus 12 days, big difference in getting patients off oxygen.
And
it took them 20 days to get.
Did any in that the similar cohort end up dying?
Yeah, so yes. So 20 patients, it took 20 days to get those patients out of the hospital versus 12 days. And then we had 40% of these patients ending up needing intubation versus only 10% with radiation. So basically all 3 endpoints are in favor of radiation. So getting them off oxygen faster is getting them out of the hospital a lot faster and preventing them from getting intubated. And now if you look at the overall survival at 28 days, the overall survival was actually equivalent. It was still 90% in both of them. And partly because those patients got intubated, they were able to stay longer because they're intubated longer, right? So when you look at an endpoint at 28 days, you got people that are intubated. We don't know what they're going to do after intubation, whether they get extubated or not. But 28 days we stop and we look at the analysis, they both end up with equivalent survival. But look at the quality of life differences and look at these, the ability to go home and all those. So all those sort of suggested in favor of LDRT. And then to dig further into the data.
LDRT stands for low dose radiation therapy.
That's correct. Low dose radiotherapy, where we gave 1.5 Ray to the entire lung. And then we looked at, to dig deeper, people wanted to see cytokines. They want to see sort of inflammatory markers. So we looked at inflammatory markers, for example. So there's inflammatory markers like LDH. It's a lactate dehydrogenase, or CRP. These are things that back then people say, you can reduce CRP, you have a signal. CRP correlates with survival in these patients. Yeah. And after radiation, we saw significant dips within 24 to 48 hours in CRP. Yeah. And then we also showed in LDH and many other inflammatory markers and cardiac markers, renal markers, hepatic markers, multiple biomarkers are also suggested in benefit of radiation. So we have multiple endpoints that suggest that LDRT would work for these patients, low dose radiotherapy, as opposed to, just getting their standard of care therapies.
So you were able to test this out with 10 patients so far, or how many total?
Yeah, so our 10 patient data, so the first 5 is already published in Cancer. Our 10 patients data that compares 10 versus 10 has also been accepted in the International Journal of Radiation Oncology, Biology, and Physics. So that has already been peer-reviewed, accepted, and that'll be coming out online probably in the next month or so.
But to me, this seems like, sorry to criticize you here, but it seems like it's going a little too slow. We've got like hundreds of thousands of people dying, yep. And potentially, and that's just in the US. So potentially millions around the world are going to die if we can't bring out effective therapies faster. So, hey, buddy, how come we're not moving faster on this?
Because, no one has paid for these trials. This is all voluntary efforts by my entire team, working late evening hours after the clinics are shut down. We work after hours. We work on the weekends. We work late. Yeah. We have a whole team of people. There's no funding for this. This is all voluntary.
And how come there aren't more people like you at every major hospital that has the appropriate equipment, that has, someone with a, radiation oncology background, that has, a friend who's a pulmonologist or
yes.
Like, how come more people like you aren't around the country, around the world, trying similar studies. So instead of just having 10 people, we've got a collective 1,000 or 10,000 people to look at.
So that's a great question. So if you look at it from February and March when we started these trials, so our first patient was treated on April 24th. There was a lot of skepticism. There was no data and nothing at all. Till May, we finished the trials. And then in June or July, a lot more people paid attention to the data and said, hey, Dr. Khan's team has shown 5-patient data and actually has 10-patient data now. Since then, more and more people have seen the data, says, hey, we need to do this. And slowly, the data is getting out there and more people are starting to do the trial. So if you look at what happened in May when we made the data available on the public domain, data from Iran came out in 9 patients. Actually, in 5 patients, I believe initially, first 5 patients. They said they also see 80% response rates, and their patients were going home in a very short time interval, where I think their average time to discharge was 6 days. So they were able to get the patient out within 6 days, and 80% response rate was using half a grade dose, lower than what we used. And that came out. And when that data came out, then shortly after that, data from Madrid came out, where they looked at patients that were in the hospital for a very long period of time. And they say, look, they treated 9 patients, and they found that their data also suggested a benefit. And with that data coming out there are more and more trials that are opening up. I know the VA Medical Center tried to open up a clinical trial of about 45 different hospitals in the US. There's an International Aging Society that is trying to run a trial in 26 different countries now because of that data. And I know Ohio State in the United States is also running a trial looking at similar signals, and they have more bandwidth and more support now financially to help run a trial. So there are more and more leaders that are rising to the occasion and helping us advance a new therapy because we understand we need more therapies until the COVID pandemic comes under control.
Yeah. And but something that still bugs me about this, like I understand when you're going through an official trial, an official program, hey, you've got to argue against your review board, you've got, your bosses, you've got to borrow the equipment. Like there's a lot that can slow this down. But maybe something that I still don't understand is, we've got tens of thousands of doctors across the country, I don't know, potentially 1 million doctors across the world that are like today treating patients coming into their hospital with, and like we said, like, a lot of these, there's like a high percentage of people who are in bad shape that are going to need to be intubated. So
Yes.
we've got like, let's say 100,000 doctors that could potentially be doing this off protocol or off label to try to save lives when they're looking at their options and they're like, okay, I got steroids. The person's dying. Like, why aren't more people just trying it off protocol? And then we can go around and collect all of that data too.
I think that's a great question. I think partly because as clinicians and scientists, we understand the data is still small and limited and weak until we have randomized trials and the government says, hey, we will pay for these large randomized trials, multiple institutions. I don't recommend using it off label at the moment. Now, to add to the data, we're about to release another 20 patient data that we've treated since the first 10 patients. So we'll make that 20 patient data publicly available. That'll help people. That'll help advance the therapy. And hopefully Ohio State will finish their trial of, I think, 100 patients. So whenever they make that data available, as the signal gets stronger and stronger and you have more confidence in the data, then I think people can start using it off label. But until now, I think we should only do it in clinical trial or start focusing on using larger randomized trials and accelerating research by funding into the research.
But why? I want to push back on you on this because, like, when the situation is so dire, I understand. Okay, we want to use trials for normal stuff, but like we are in emergency mode here, and like not everyone has access to great medical care, across the world. Like I can only imagine what the situation is like in a country with limited medical resources, where the people aren't so rich. Like they don't have the hospital beds, the 12 days to treat people. To me, this sounds like something that, someone's about to be intubated, you give them a blast over 15 minutes, and then if they could be out the door, it just seems across the world, the situation is just so much more dire, and that it's worth trying more off protocol work. If the potential is, like, we're talking about saving hundreds of thousands of lives.
No, I understand. I think you raise a good moral and ethical dilemma about the scientific rationale, the scientific data, integrity of the data, and the robustness of the data versus the pandemic era. But I think the reality is the data is still very minimal. We only have 3 institutions that have reported data: Emory University, our data, 10 patients. We will add 20 more patient data to that coming out probably the next couple of weeks. Iran has their data. Madrid has their data out there, but the data is still weak. What if all of us got lucky and the first 10 patients, it worked, right? Or the first 9 patients, how many we treated so far, it worked. But what happens with the next 100 patients or 200 patients? And we're trying to amplify that signal across millions of patients across the world. And we may hurt patients because the data is not robust enough. And
but that was also true with hydrochloroquine and remdesivir, but those were used by thousands, if not hundreds of thousands of doctors across the world off-label just because we were desperate.
I agree. No, that's a very good point. Honestly, I agree. I mean, I think, hydrochloroquine was used off-label, and even when the data was negative, people still kept using it. People are still using it today. That's kind of unfortunate. But, the reality is, I think we have to be scientists, and we have to be very critical of our work. I think we have to be, very careful. So to me, I would still be skeptical. I would still want high, robust data. Just saying at some point, yeah, we can use off-label, but I don't think we're there yet. But I think this is where, if there is an urgency and a sense of wanting to move this forward, I would encourage, all agencies, the National Institute of Health, NCRP, any philanthropy, any funding agencies, whoever has the funds to want to move this forward. We're not a drug company. It's not like there's inherent money to be made in this, right? So drug companies are different. With hydrochloroquine, they have money to make, and they have a huge stock following. They have funds, so they can support their research and get that done. Remdesivir, similarly, pharmaceutical companies have funds, so they pay for all this research. With radiation oncology, I don't see a lot of big radiation equipment manufacturers saying, "Hey, let's do this research, let's accelerate this, let's fund it, let's get it out there." Or the government agencies want to say, "Hey, we really care about the pandemic, and we want to support this research," and that'd be great if they did.
But to me, though, that seems even more of a reason that doctors should be trying this off protocol, because there isn't this machine behind radiation like there is a machine behind these drugs promoting it. It seems to me like the pragmatic reality is that if doctors don't, take it up to themselves, that we're going to be desperately asking governments to help fund this for the next year while countless of people suffer. I feel like I understand you're cautious. You're cautious as both a scientist and a doctor, and I'm not. I'm an entrepreneur, so I just want to make stuff happen. But I still feel like how dire the situation is, not just in the U.S. but across the world. The bigger risk is waiting. Like even if you were correct and we got the money to do the clinical trials, if we delayed that even 1 month, we're talking about potentially, another 100,000 lives across the world that are lost just from waiting. So it's like, I don't want to wait. I want to test everything. I want to throw it at the wall. I want to see if it works. Controlled trials be damned.
Yeah, no, I agree. I think this is where it really boils down to the individual sites across the world. How strongly they feel with 10 patient data, 5 patient data. And there's many cases in the medicine where people take off the shelf and apply, but that's up to them. At their level of whatever they feel in their comfort level. I think that's fine with them if that's what they want to do. There are case reports out there that are published in medicine, and we just take individual case for 1 or 2 patient case reports, and we apply this. I'll give you an example. Like there was a young lady that I'm treating right now with acrin fibroadenoma. It's a very rare histology. There's only a handful of case reports in the entire world, and that young girl has failed all therapies for her. We know radiation worked for her brother. It worked for her dad, and she actually got the things that is not working for her feet, and she has no other option left other than having her foot amputated. And she's a young lady, and that's not acceptable for us. So we, and we only have a case report where we know radiation works, and that data is even weaker than the data for LDRT. But I'm using that case report and ran it through our moral and ethical board, and we're doing it all protocol and actually radiating her. So, and she accepted the risk and benefits, but that's an individualized decision making on an individual level. At what point do you feel like evidence is enough to treat? And there are many cases where things are done off the shelf, but that's more of an institutional level. But from a global level, from a pure scientific level, from a more, the way things are done, scientifically, we're not there yet that we can do it across all places, all institutions, until we have a randomized trial that compares LDRT versus standard of care. Now, my phase 3 trial is open. I am running a randomized trial right now. It might take 6 months or a year for me to get that out. And my research is becoming exhausted, and I don't know how long or how quickly I'll be able to generate the data. But that phase 3 randomized trial is ongoing here in Emory, and we plan on treating about 150 patients. And right now we've got limited resources, so it's going very, very slow. I've reached out to several agencies to seek funding for that phase 3 trial, but I'm encouraging others to at least help champion that, and even other places, to see if the theory works. And if it does, right, then we have the data much quicker. But then we can make it much more standard of care to saying, hey, it worked. It's like remdesivir. They actually did a phase 3 trial. They have thousands of patients in that trial. Similarly to the hydrochloroquine, they did thousands of patients. They found out it didn't work. But at least remdesivir did the phase 3 randomized trial, has some benefit, not the benefit we hope for, but has some benefit. Steroids, on the other hand, had a large 6,000 patient data trial. It was run at the government level in England, and they made that a standard of care. So they accelerated their research. So similarly, I would encourage people to say, hey, look, we may have a potential therapy. If you want to sort of make it fast and make a standard of care, then let's do it fast. Let's do it quick. Let's get these randomized trials out. Until then, I have to be very skeptic. I have to be very cautious. The data is very limited, and any decisions at the individual level can be made at the individual level. But at a global level, I think we have to be careful and cautious about the data we currently have. And as scientists, you can only go with the data you have and the limited, and you have to understand it could be just, anecdotal. It could be, luck that the institutions that reported, we just got lucky, maybe, who knows?
Yep. All right. Well, Dr. Mohammad Khan, thank you so much for your time today and walking us through this. I think the work that you're doing is, super important, and I hope I can share it with the world and help encourage your efforts. But thank you again for taking the time.
No, appreciate. Thank you so much, Brett, for giving me the opportunity to discuss some innovative research and some potential new areas we can grow into and help patients get better and prevent them from dying. I appreciate it. Thank you so much.
And initiate at least a new approach to the many difficult problems that must be solved in both private and public conversation if the world is to shake off the inertia imposed by fear and is to make positive progress toward peace.